talk of cataract, usually the symptom that really comes to our mind is just decrease in visual acuity, but it's way more than that. The quality and quantity of the visual acuity that is compromised is also associated with many other factors. So usually the patients will complain of cloudy or fuzzy or foggy vision. So the words can be different, but in the end they just want to say that they have a visual compromise which is precluding their day-to-day activities. Some of them will complain of problems while they're driving at night, and they'll complain of lot of glare, especially when they see a headlight of a forthcoming vehicle. And some of them will complain of the same during the daytime. Some will say that they have frequent change in their eyeglass prescription. They will even find difficulty during reading. And some will have complaints only for their distance vision. And some will find sudden changes like change in the contrast of different objects and changes in color perception. So the more attentive a patient is to their visual needs, they'll be able to pick and define their symptoms to you. So in this image, we see that if a patient is having cataract, the light is not getting focused, it is getting diverged. So you will have the lens opacities, they will break down the light rather than focusing it on the retina. They will break it down and make it so fuzzy that the image loses its sharp borders. As we can see in the upper quadrant, the images become fuzzy, unlike the image on the bottom where the borders are much sharper. So for whom should we consider cataract surgery? Should it be given to one and all? And what is the cutoff visual acuity at which you decide that this patient needs to undergo the knife? So the visual requirements, they vary from person to person. So somebody who is doing a desk job on a computer for about 6 to 7 hours a day, his visual requirement is way more than a farmer who's just doing macro work in the field. So the requirements vary from person to person, and surgery is indicated only if and when the cataract compromises their day-to-day activity. So this young gentleman is not able to see the PowerPoint presentation he's just about to present, and his vision is just 6/12. So to you and me, it will look that, he's just not able to read the last 2 lines. Why do we need to give him a cataract surgery? He can just do with the glasses. But he is getting a lot anxious because he's not able to see any details. So for him, cataract surgery is required. Unlike this elderly gentleman who's working in the fields, for him, you can wait for a bit longer. Even 660 vision can make him function in the fields. So the visual requirement is different. There is no cut-off visual acuity at which you decide. But now we have a revolution of computers, and you can have farmers with computers who are really going to be tech savvy. And so you will have to redefine your visual acuity criteria to consider them for surgery. There are some medical indications also in which you need to consider doing a cataract surgery when a cataract is adversely affecting the health of the eye, as in cases with phacolytic or phacomorphic glaucoma, where the lens is leaking proteins, as in this image. You need to consider doing an urgent or an emergent cataract surgery. Sometimes the cataracts, they do not allow you to view the posterior segment. And in a patient who is a diabetic, you need to be able to dilate them repeatedly every 6 months to 1 year to be able to see if they are developing any diabetic retinopathy. So you really need to remove this wall of cataract so that you can see what is lying behind it. And in certain conditions, such as in patients who have had some trauma, you can have a traumatic cataract, and that also needs to be addressed soon. There are some cosmetic indications. So the patient may be blind, he can have no perception of light in that eye, but still have a mature white cataract. So in these patients, you are doing a cataract surgery not for giving them vision, but for giving them a cosmetic outcome. So in such cases also, cataract surgery is considered. To have a good post-operative outcome, you really need to put in some extra time when you're working up the patient. You have to be really vigilant and look at all the structures carefully in both an undilated and dilated state. So what questions should come to your mind when you're doing this workup? The first is that, does this lens opacity, it correspond to the visual impairment? So say for example, if visual acuity is, say, counting finger 1 meter, and when you dilate the patient, you see that there is a very minuscule lens opacity, and that cannot explain the 1 meter visual acuity. You really need to dilate and see what's there in the fundus, and sometimes you may be surprised to find a finding sitting right there. So you have to be able to correlate the visual acuity with the amount of cataract. That's really, really important. And does the patient that you're working on have reduced ability to function, and therefore does it warrant surgery? So as I mentioned, that young gentleman we saw who was working on a computer, who works in a corporate sector and has to do a lot of work on the computer, for him 6/12 can be really, really debilitating. So for him, this warrants surgery. Is this eye that you are examining sufficiently healthy to expect improved visual function if surgery is performed without complications? So here we have an image. If you can see that there is festooned pupil, there are some abnormal blood vessels on the iris, and there is hypema. So this is a diabetic patient who has neovascular glaucoma. Although he has a complicated cataract, if I jump upon to do a cataract surgery for this individual, by virtue of the complications that he's having because of his diabetes, I'm going to have a very bad outcome. So unless I address the neovascles that are there on the iris and the diabetic retinopathy, unless I address those two things, I'm not going to have a good outcome. So I have to see that other conditions are also taken care of. And is the lens opacity that you are seeing is secondary to a systemic or an ocular insult? So all the cataracts are not because of findings that you see in the eye. There may be some systemic findings somewhere else which may give you a clue to the systemic condition. Unless you address that systemic condition, the post-operative outcome is not going to be very desirable. So general health of the patient is really, really important. So you have to know, you have to ask the patient, are you a diabetic? What medicines are you taking? Are you taking oral medications or are you on insulin? You need to see if they've had a controlled status of their diabetes. So you can get a HbA1c done, the glycosylated hemoglobin, which gives you an idea about their glycemic status over past 3 months. See if they are hypertensive, because if you have a high blood pressure on the table, you can end up with a hemorrhage on the table. If they have any bleeding disorder, are they on any blood thinners? Because if they are on any blood thinners, they have to be stopped after consultation with the physician. And if they are an asthmatic, or if they are taking any inhaler for that, because sometimes when you drape the patient, asthmatics can have an attack of asthma. So all these small things, they have to be taken care of. And if required, please do consult the physician before you take up the patient on your table. Now, I talked about multiple systemic disorders that can have manifestations in the eye, and in addition to other manifestations that we would be covering in the subsequent lectures, there are many systemic conditions that lead to very typical types of cataract, and these typical types can also come as an MCQ for your NEET exam. So we have a systemic condition which is called as myotonic dystrophy. It leads to something called as blue dot cortical cataract. We'll be seeing the images in the forthcoming slides. Wilson's disease results in a sunflower cataract. Hypocalcemia results in discrete white cortical opacities in the lens. Diabetes mellitus results in snowflake opacities in the lens, and atopic dermatitis, which can be seen in asthmatics too, results in blue dot as well as posterior subcapsular cataract. So here we have a very, very typical snowflake cataract. Look at the crystal-like formation on the lens. So all this will become visible only if you give time and dilate your patient. A quick look in an undilated pupil, you just see a gray reflex right down immature senile cataract, is not the way to go. Christmas tree cataract, which we see in patients with myotonic dystrophy. So here is a Christmas tree and a very, very similar polychromatic luster that you see in this patient in their lens. A rosette cataract, which is seen after trauma. Very, very typical spoke-like features as you see in a rosette, very typical.